Welcome to the ERA EDTA's CKJ Journal Club. Each seminar takes place the last Thursday of the month at 1700 Central European Time or 1600 UK time, and we pick out a topic from a recent CKJ original research or key review article, and the author or authors will introduce their work. It will include at least one expert on the panel and will be moderated by myself. I'm Will Herrington. I'm an Oxford-based nephrologist and epidemiologist, or CKJ Editor-in-Chief, and Professor Alberto Ortiz. We talk for an hour. It'll be fairly informal, but we encourage live and hopefully lively questions to be typed into the Q&A box, and it'll be recorded and made available on various platforms afterwards, so keep an eye on social media for links. And this is our third e-seminar, the first of 2021, and today's discussion is around a subject that's close to my heart, and I suspect I will be close to many of you listeners' interests. It's the topic of sodium glucose cotransporter 2 inhibition, SGLT2 inhibition. And there are now 10 large placebo-controlled trials which have reported the effects on cardiovascular and renal outcomes, including 2 which have been dedicated CKD populations, Credence and DAPA-CKD, and together they're providing really important information about the clear clinical utility of SGLT2 inhibition in modifying risk of kidney disease progression in certain patients with proteinuria, as well as safely modifying glycemia. And KDIGO is now recommending their use in patients with type 2 diabetes with an eGFR over 30. And importantly, CANagliflozin has an indication for treating diabetic nephropathy with albuminuria to slow kidney disease progression. So we're going to start to be using these in our practice as nephrologists, and we need to be able to counsel our patients carefully and monitor them appropriately. And so today's topic is about SGLT2 inhibition and potassium. It was the subject of Dr. Matthew Weir's original research article using data from the CANVAS trial. Professor Weir is Director of the Division of Nephrology at the Department of Medicine at the University of Maryland in Baltimore. He's interested in diabetic nephropathy and cardiovascular disease, and also mineralocorticoid receptor antagonism, which is all relevant today. I'm sure that many of you will have heard his enthusiastic presentations in the past. So welcome, Professor Weir.
Well, thank you very much. I appreciate being here and look forward to participating with you today.
That's great. And our expert panelist is also synonymous with the words SGLT2. It's Professor David Cherney, who's professor at the Department of Medicine at University of Toronto and a clinician scientist at the University Health Network and Mount Sinai Hospitals. He directs the renal physiology lab there. So thank you very much, David, for sparing time in your busy schedule.
Oh, pleasure. Thanks for having me, Will. And it's good to be here with you, Matt, and the group, and with Alberto as well.
Great. And the session will today be moderated by both Alberto Ortiz and myself. So probably without further ado, Professor Weir, the floor is yours. Please, could you begin your presentation for us?
Well, thank you. It's a great pleasure and an honor to participate in this important ERA EDTA meeting. I enjoy very much coming to the conferences and look forward to participating in the future. My topic today will be focusing on aspects of these newly defined renoprotective drugs on serum potassium, which of course is important in our patients who have chronic kidney disease, especially if they have reduced kidney function and or diabetes. The next slide will, if I can advance it, for some reason I can't. There it is, are my disclosures. You'll note that I have served as a scientific advisor to many of the manufacturers of SGLT2 inhibitors, none of which will be influencing my conversation today. My federal grant funding is not related to the topic of today. I think we can all appreciate that we would prefer to use evidence-based approaches to the care of our patients with diabetic kidney disease, including better blood pressure control, appropriate doses of renin-angiotensin system blockade, coupled, of course, with other issues like glycemic control, acidosis correction, and albuminuria suppression. And certainly we're learning a lot more about the pathophysiology of kidney disease progression in people with diabetes. And we've all learned a lot about the serendipitous observations of the benefits of SGLT2 inhibitors on the progression of kidney disease. But we need not forget that these studies in large part have been done in patients receiving appropriate doses of renin-angiotensin system blockade, and especially those, all the chronic kidney disease studies that are either been completed or are currently being conducted. And we do know appropriate doses provide a 20% relative risk reduction benefit. But we also know, too, that many of these patients have problems with hyperkalemia, which limits the use of these drugs, both in appropriate dose and being used at all. And we know hyperkalemia is prevalent, particularly as kidney function deteriorates, especially in patients who are older and may have diabetes. And this has been well described in a number of kidney disease progression studies, where the absolute rates are substantial. But even more important, many of you and I in clinical practice have even more problems with potassium that is often noted in large-scale clinical trials. Our response to this, though, unfortunately, is either stopping the drugs or reducing the drugs. And unfortunately, we have to remember that reduced dose of RAS inhibitors in people with diabetic kidney disease does not confer the same degree of renal protection. And I think that's an important issue as we consider how best to provide care for our patients. It's a critical conundrum. And so our standard care really is to titrate or discontinue these drugs. And there are other opportunities as well. But when we start to consider the data with the SGLT2 inhibitors, of course, the question comes up is how safe are they, and can they be used in people with much reduced renal function? And the mechanistic question still remains an important question. A lot of people have suggested that it may be related to reducing glomerular capillary pressure, which may be true, particularly if they have good kidney function. And as Dr. Cherney will discuss, he was one of the key investigators to look at this particular issue. But we also have to appreciate, too, that there are some problems with this thought that it may be a critical factor based on some of the issues you see outlined here. And maybe we could have Dr. Cherney discuss a little bit later more about this as we look at the data. But I think we still have to learn more about the mechanistic benefits of these drugs, because that may explain more about whether they do or don't affect serum potassium and how they might provide protection against kidney disease progression. Many people think the blood pressure part of the equation is important, and I am one of them. I do believe there are many other effects of these drugs, but one cannot escape the fact that blood pressure does go down with these drugs, and even in people with advanced kidney disease, which is remarkable when you consider the fact that one of the principal theories behind their antihypertensive effects was natriuresis, in part related to the glucosuria. But of course, that's not prevalent in patients with much reduced GFR. What does appear to be clear as you look across the spectrum of previously completed clinical trials shown here is that the benefits are consistent regardless of GFR. And this has been expanded more recently with the completion of the Credence trial results shown on your right, as well as the DAPA-CKD study, which was recently published, as well as I'm sure will be echoed in the EMPA kidney study that is nearing completion as we speak. But the consistency of the benefit does raise concern as to why these drugs are not yet used more commonly in clinical practice. And appreciate that these observed benefits are seen regardless of kidney function, regardless of proteinuria, even regardless of whether the patients have diabetes or not. And we also have to remember these observations are conducted in patients with renin-angiotensin system blockade on board. So more to the data that we conducted in a retrospective look at the CANVAS program data. Please recall that this was a trial to demonstrate safety from a cardiovascular standpoint in people being treated with CANagliflozin versus placebo. You can see it was a compilation of 2 clinical trials involving more than 10,000 people, and the primary consideration was cardiovascular safety. There were no considerations at that particular juncture as to whether or not there may be cardio or renoprotective benefits. Those observations were largely serendipitous. But I think the bottom line is the drugs were safe and, in fact, beneficial on both cardiovascular and kidney outcomes, despite the fact that they were not designed to truly examine whether or not this was going to be the case. So I think it's important for us then, from a safety standpoint and clinical utility standpoint, to look at the data. And I'll show you a number of graphics here. This is mean serum potassium level in the overall group. And what I'll do next couple of slides is share with you the data in people with reduced GFR during the course of the study. And please appreciate that there is the subtle suggestion that, in fact, the serum potassium levels may be somewhat lower in the patients receiving the SGLT2 inhibitor compared to placebo. Now, this is the overall group of patients. These are people with GFRs that are above 60. Again, the suggestion of a slightly lower serum potassium in those receiving the SGLT2 inhibitor. These are people with GFRs below 60. The similarity of the data across the board, pretty close. Again, no real signal that the potassiums may be less. I think clearly neutral is the main observation here. And then if you look at the selected patients, fewer numbers now, of course, below 45, you will again see evidence of no adverse signal on serum potassium, and if anything, perhaps slightly less. And so I think the totality of the data suggests that using an SGLT2 inhibitor with a drug that blocks the renin-angiotensin system in totality is safe. It does not appear to affect serum potassium, and in some patients, it may even help reduce it. To further examine the potential changes of SGLT2 inhibitor therapy in these patients, we've done more analyses to look at serum potassiums in the first set there, where it's less than 3.4. So it doesn't appear that that happens. If you look at potassiums over 5.4, that doesn't really appear to happen either. And then overall potassiums over 5.5, over 6, or over 6.5. Again, the totality does not appear that the drug CANagliflozin alters the serum potassium levels to any significant degree. It always crosses the line of identity, which is 1.0. And again, if you look at the p-value for heterogeneity, there is no statistical significance suggesting a change. I'd like to also share with you the study done with CANagliflozin, done in people with established diabetic kidney disease, to look at the serum potassium levels there. And as you will recall, this was a study in about 4,400 people who were randomized, like the CANVAS study, to receive CANagliflozin versus placebo. But the difference is this particular clinical trial was originated and started before the cardiovascular outcome safety trials were completed. And the whole purpose here was to establish as a primary outcome whether or not one could provide kidney protection, as you can see there. You will also note here that there are a substantial proportion of people who had GFRs below 45, even a few below 30. And you will notice that there was a substantial amount of proteinuria. And again, this was designed this way a priori for examining protection against diabetic kidney disease. I think we're all aware of the established benefits that were shown in this clinical trial across the board, whether or not you looked at a kidney or a cardiorenal outcome. But what's interesting to me, even in this group of people who are going to be much more likely to have potassium problems, you will notice again that there are somewhat fewer hyperkalemic events in the CANagliflozin treated patients compared to placebo. Now, again, this is not statistically significant, but again, the hint at there may be a benefit here. And of course, one has to question why. I mean, these people were all on highest possible tolerated doses of renin-angiotensin system blocking drugs. You kind of wonder whether it's a direct effect on the kidney, or whether or not maybe it's better preservation of good kidney function. I mean, we just don't know. But there is the hint of less hyperkalemia. And I might add, this similar observation was observed in a large heart failure study that was conducted with dapagliflozin, called the DAPA-CHF study, where there was also evidence, despite intercurrent other therapies for heart failure, where there were indeed somewhat lower serum potassium levels. So I would summarize my conversation with you by basically stating we obviously need intensification of traditional treatment goals and using appropriate doses of renin-angiotensin system blocking drugs. I do think newer treatment approaches, such as SGLT2 inhibition, has changed the playing field and should be part of our standard of care now. And I also think, too, as we evaluate the benefit to risk ratio of these newer therapies, there certainly appears to be less of a concern rather than more of a concern with regard to serum potassium. And thus, I think we can safely continue to recommend the use of renin-angiotensin system blocking drugs. And perhaps also we can expand that now with the recent Fidelio study with mineralocorticoid receptor antagonism. And I know both Dr. Cherney and I will talk more about that a little bit as part of our established approaches to treating people with chronic kidney disease. And this dilemma will continue to be an important part of our concerns moving forward. So I think, again, this is an important area we do need to remember and we need to be responsive to. So I think in summary, what we have seen from the CANVAS study is that quite clearly the use of an SGLT2 inhibitor is safe from a cardiovascular risk standpoint. If anything, there may be opportunities for both cardiorenal risk reduction benefits. We certainly observed in the CANVAS study neutrality with regard to serum potassium levels, if anything, perhaps a slight reduction in some patients. And I think this is an important area because potassium remains an important area for our concern moving forward in people with established kidney disease, especially if they are older or with diabetes. So I think from a clinical practice standpoint, I think we can feel comfortable using these drugs from a serum potassium standpoint. And I think this may expand our use for providing better kidney protection in our patients with both diabetic and non-diabetic chronic kidney disease. Thank you very much for your attention. I'll turn the meeting back over to Will and help us along with the Q&A opportunity and my good friend, Dr. Cherney.
Thank you, Professor Weir. That's great. I think we are being spoilt by the amount of evidence we're now being supplied about SGLT2 inhibition. It's great to be able to focus in so specifically on potassium. Maybe I could start by turning to you, David. CANVAS is a wonderfully large trial. It's a continuous outcome measuring potassium. It should have enormous power to detect even small differences. I have to admit my hypothesis before I saw these data would be that because SGLT2 inhibition has an acute effect on EGFR and because it might decrease serum potassium, reduce ammoniogenesis in the kidney. I was expecting potassium to go up very slightly. So what were you expecting? Can we explain why we've got acute changes in EGFR and potassium's going down? Is there another mechanism in the kidney or elsewhere that you think might be acting?
Yeah, thanks, Will. So that's a really important point. And I think part of the conundrum in the area around what we expect to see with potassium is that there are a variety of competing physiological effects, as you alluded to. So on the one hand, there is the dip in GFR, which would be expected perhaps anything that reduces GFR should raise K. And so there may be a raising influence and hyperkalemia inducing influence, but with the reduction in GFR that we see at least initially with these therapies. But on the other hand, there are other competing effects, especially around natriuresis and increased luminal flow with these therapies, because they do have a diuretic and a natriuretic effect, at least initially, that's likely pretty transient. And so that may actually increase potassium excretion and thereby lower serum potassium levels. And then there are other influences potentially as well around tubular acidification with SGLT2 inhibitors that have really only been looked at in experimental work in knockout animals of sodium hydrogen exchangers that may also potentially influence the kidney's handling of K. So there are lots of competing interests, and at the end of the day, we needed some empirical evidence to see which of these influences actually wins out. And so based on previous work, and some of this work was done by Dr. Weir, and some of it was done with dapagliflozin in the last 5 years or so, looking at just in an exploratory way at previous databases to see if there is a directional effect on potassium or an increase in electrolyte side effects. And the message is that the data have been extremely consistent with what we've heard today, in that there is a trend in this previous work for a reduction in potassium in this very same sort of order of magnitude of around 0.03 to 0.05 milliequivalents per liter in serum potassium, with generally statistical neutrality, so crossing the line of unity. So I have to say that based on that work, I would have expected a tendency for a reduction in potassium. But also, I think the other work to think about very carefully is the sort of kidney stress test that some of our patients go through for potassium when they're treated with a mineralocorticoid receptor antagonist. And we know from, at least from abstracts that have been shown from the DAPA-HF trial, that in patients treated in DAPA-HF with dapagliflozin and an MRA, the risk of having significant hyperkalemia tended to be reduced. So, based on the work by Dr. Weir and by others in an exploratory fashion, as well as the data in patients with heart failure who were treated with an MRA, which tends to raise serum potassium, I think the weight of the evidence is very much consistent with what we see in the analyses from Canvas and Credence that we heard from Matt today, with a tendency for lower potassium levels. And so I think there's consistency, but maybe not a clinically significant effect that we could actually see in an individual patient when we're treating them in clinic. That may be very hard to detect, but overall, very much reassuring, as Matt suggested in the conclusion. I think the takeaway message is that it's very reassuring that there is very little effect, if anything, a tendency towards lower potassium levels, maybe on the basis of the natriuresis. Maybe I'll stop there for a moment.
Yeah, so that's really interesting, David. I was wondering if you had thought about gut losses of potassium. I think people quite honestly are seeing the SGLT2 inhibitor class having very similar effects on a lot of the cardiorenal outcomes. The only real difference I can see between them is some of the specificity for SGLT1, with CANagliflozin having perhaps one of the lowest levels of specificity for SGLT2 and empagliflozin the highest. Do you think that the sort of reductions in potassium might be more tended towards CANagliflozin and less towards the other drugs? And maybe what about sotagliflozin? Do we know anything about that drug?
Yeah, so in terms of the magnitude of the effect, it seems to be numerically, my read of the different analyses is that it seems to be very, very similar, regardless of these small changes in specificity that probably aren't clinically important with regard to gut absorption. And then for sotagliflozin, there probably is a signal for some gastrointestinal intolerance with sotagliflozin that we see from the SCORED and SOLOIST trial that probably wasn't this. It was probably exaggerated compared to the GI intolerance with the more selective SGLT2 inhibitors. I would suspect clinically you'd have to have significant consistent diarrhea and GI loss in order to really see a clinical significant effect, and that wasn't reported in the trials that we have to date from Deepak Bhatt and others. So I don't think that clinically we really have information that there's a distinction between the different inhibitors, even though there are pharmacodynamic and pharmacokinetic differences between the drugs, especially around selectivity for SGLT1 versus 2.
Now, I wonder, it's a fascinating question. And you're right. If you're not having frank loose stools, my suspicions are that GI losses are less likely to be predominant. I still wonder whether there are alterations in renal tubular epithelial handling of potassium. And the theory of either greater fluid trafficking through the tubule or sodium trafficking through the tubule, I think is a reasonable one in people with better kidney function. But in people with marked reduction in GFR, it's so much less of an issue. Let me throw out another idea. What if there could be a potential impact on choice of foods, given the fact that these people tend to lose weight, and whether there might be a central effect, which I think would be a fascinating question. I mean, we're still in our infancy of understanding how these drugs work. I mean, it's really remarkable how little we know. But whether that could possibly play a role.
Yeah, and given the fact that food choice decisions and different kinds of food haven't really been part of the trials, it would certainly have to be looked at in a dedicated analysis, I guess. But it's certainly an interesting question. And similarly, around the selectivity, as you noted in your slide deck in the introduction, SGLT1 is involved in TG feedback mechanisms and in entry of sodium into the macula densa cell, and may play a role in mediating some of these feedback mechanisms. So that's also an interesting thing to think about around how it mitigates or modulates the vasoconstrictive effects of these therapies, 1, and 2, whether there's an impact on acid-base balance in tubular cells, which could also impact on potassium handling. I think the only data we have to really think about that is genetic knockout models from Volker Wallin, who's done some of this work in sodium hydrogen exchange knockout models, and really didn't show. There were changes in urine pH and bicarbonaturia, but there were no changes in electrolytes despite influencing sodium hydrogen related pathways. So it seems less likely from a renal handling perspective. But I like the idea of food intake. That's certainly an interesting thing to think about, both in terms of mechanisms, but also for management. In patients who do get hyperkalemic because of other medications, for example, I think that it emphasizes how important it is to also think about diet intake in patients with hyperkalemia with diabetes.
So I wanted to talk a bit about clinical implementation of SGLT2 inhibitors, because I think all of us are beginning to use them, but monitoring after you initiate the drug is somewhat less well sort of an evidence-based space. I want to talk about monitoring for the acute change in eGFR in a minute, but if that aside for now, do you think there is any specific group of patients who might need enhanced monitoring for potassium? And I'm going to actually read out a question here from Ana Caterina Gomez, who's written in the Q&A section about one specific group, which I think is interesting, and I think it comes directly from one of your points, David. Considering potassium levels may be maintained during natriuresis, and although sodium excretion is minimal and transient with SGLT2 inhibitors, do you believe that people with hyponatremia should be monitored more closely when initiating an SGLT2 inhibitor?
Yeah, so I think that's an important point, especially around the use of these therapies in heart failure patients who tend to have a higher risk of developing even modest hyponatremia, sodiums of 130 or 132 or a little lower than that. And I haven't been concerned about starting SGLT2 inhibitors in those patients because of the lack of signal around sodium changes in patients being treated with SGLT2 inhibitors in clinical trials. However, in patients with baseline levels of hyponatremia that I think is clinically significant, I think it's reasonable to include those patients in the category of individuals who should probably be checked after initiation of therapy, not only because of the sodium, but I think it reflects, because of the hyponatremia, but I think it also reflects an underlying physiological fragility, for lack of a better term, in terms of their overall risk. 1, 2 is they're probably at higher risk of the cardiorenal syndrome and some renal hypoperfusion. And in those patients, that's a group where you might consider checking just electrolytes and sodium, sodium, potassium, creatinine, perhaps 2-3 weeks after initiation of therapy to make sure that things are still stable afterwards. So I think that's a very reasonable approach in patients with that kind of profile. Matt, what are your thoughts about that?
I mean, it's interesting. I mean, to theorize that, the practical reality is if you look at the heart failure studies that have been done, we have quite a bit of data now. Hyponatremia really hasn't been a problem. And there's a problem we have to remember here about all of these studies is that there's so much other medical co-therapy that can be adjusted and changed by the investigators. And, one of my theories about the advantage of SGLT2 inhibitors on kidney function in heart failure patients is that, in fact, many of the investigators may be pulling back on the loop diuretic support. And, just because the heart's working better. And this could potentially obviate problems with hyponatremia, low blood pressure and the like, and pre-renal, characteristics in some of these patients who are over-diuresed. So for my money, I'm still fascinated about the whole issue of RAS blockade, ALDO blockade, and SGLT2 inhibition, because we're running into the same problem now, which is a good problem, don't get me wrong, where we actually have choices in people with CKD. The heart failure people got us beat. They got beta blockade, they got ARNI, ACE or ARB, they have, they have, but now we're running into the same problem, which is a good problem. But what's the best grouping of these drugs to really slow the process down? And what influence that's going to have on potassium, sodium, blood pressure, and everything else. I for one, am fascinated by the fact that if the potassium with these drugs is actually not changing or going down a little bit, what is the reflex change in the serum aldosterone level? Which is a fascinating question because we did some studies that we published a few years ago in KI when we gave patiromer to people with CKD. We saw a complementary reduction in aldo with reductions in serum potassium. And you kind of wonder whether we might be seeing the same thing now with an SGLT2 inhibitor. I just don't know.
Yeah, and we do see with initiation of therapy in patients who are naive to RAS blockade, initiation of an SGLT2 inhibitor does tend to physiologically raise aldo levels by a very small amount, but that's a little bit harder to predict in patients who are on, RAS inhibitor, aldo blocker, etc. This is in people who typically aren't on those therapies and don't have heart failure. So what happens in patients with heart failure is less well understood. We have a paper in press in diabetes care looking at the effect of ertugliflozin in patients from the Virtus renal trial, patients with impaired kidney function, and we saw at least an initial rise in aldo levels at 26 weeks, which tend to attenuate over time. suggesting that there is an initial a small effect on plasma volume contraction, which raises levels of circulating RAS markers, tends not to persist though. So how that modulates over time is also something that needs to be further elucidated, but may even be beneficial because it reflects the plasma volume contraction, which may be protective over the long term.
Of course, you have to look there also too at the serum potassium levels, because that can also alter aldo as well. So I mean, it becomes quite complex when you look at all these juggling
competing effects. 100%, I fully agree.
So can I ask a bit about what your clinical practice is, Professor Weir, when you start an SGLT2 inhibitor in terms of monitoring? And I get from these evidences, it suggests to me that there isn't any need to introduce any additional monitoring, at least for potassium. I've got a slight bugbear in the recent national guidance in the UK, which is in draft from on NICE, was suggesting that there was need for increased monitoring of EGFR on starting an SGLT2 inhibitor. Yet KDIGO have said the acute drops are expected and are not usually a reason to discontinue treatment. So when we start RAS blockade, I think we're all used to doing a blood test a week or two later to look for large changes in creatinine perhaps as a result of any underlying renal artery disease, but also to see potassium changes. What's your practice when you start an SGLT2 inhibitor?
Well, I've been using them for a number of years, actually. I was an early adopter. I'm of the philosophy of fire and forget. I put them on it. I don't do any additional blood work at all. To be honest with you, my own personal perception of using these drugs in people with reduced kidney function is that they're probably safer than an ACE or an ARB. And I see less of a change in kidney function, if at all. Maybe because I'm not looking, but I don't see it. I don't see changes in potassium. I do see reductions in albuminuria. In some patients, I can see subtle changes in blood pressure, not substantial. But I don't do any additional testing at all. I mean, literally, and particularly in people with more reduction in kidney function, where they're less likely to have any, true effects related to glucosuria.
Yeah, so that's typically my practice too in patients with GFRs of over about 35. In patients with lower GFRs, I'm moving towards that, but I still have less experience with using them, initiating them in people with GFRs of under about 35. So I have to admit I'm still checking at about 2 to 4 weeks in those patients just to make sure that there isn't anything unexpected, but I'm certainly moving towards what you're doing more and more.
So that's really interesting, David, because I was looking at the DAPA-CKD result for hyperkalemia. It's in the supplement of the New England Journal publication. It's 12 versus 16 serious hyperkalemias. So if anything, numerically lower amongst those allocated to dapagliflozin. And obviously that's a group with much lower EGFR than a lot of the other trials. Are you doing any exploratory work to look at the 2 to 3 week visit in DAPA-CKD? Because I think now that people are adopting these drugs, it'll be very helpful to know how easy they are to implement. It'd be very interesting to see how often a drug is stopped because of a repeat blood test and whether there's a difference between placebo and dapagliflozin allocation.
Yeah, no, those analyses are very important. I agree with you, to better understand not just the physiological effects, but also the clinical implementation. I guess one of the reasons in patients with lower GFRs where I still haven't gotten away from checking is that in the trials we did check. So,
yeah.
So
what did it show though?
Now we know it's pretty safe. So we had that blood check, we had that blood work done early. So that's kind of what I adopted, but I think it's probably unnecessary in the vast majority of patients.
Yeah. So in EMPA-Kidney, we had a look at it with at least the EMPA-REG outcome type data. And it was reassuring for us to just do a measurement again at 2 months, not an acute extra measurement. Obviously, investigators are free to have a look like you're doing. But I think when I heard Matthew say fire and forget, it's great. It reminds me of LDL lowering therapy. Put them on appropriately intense LDL lowering, fire and forget. And I think SGLT2 inhibitors, if we can demonstrate that they really are that safe, may well be moving to that type of sort of risk modifying type category of agent.
Yeah, my theory is these drugs may actually be safer in people with more advanced chronic kidney disease, because a lot of the concerns about ketoacidosis and volume depletion and all this other stuff, which came out early on, clearly, if you have no glucosuria, why would you wouldn't even have these issues. And I that's what we may be moving into that direction. But I wanted to go back to one of the things you said about EMPA-REG. We've done analyses, and I think, David, you were part of some of these, where we looked at intercurrent use of other drugs, including diuretics, which was, more of a concern with, implementing with these. And we really didn't see any issues related to safety or blood pressure changes or dipping or anything else that was of a substantial concern. I still think and would support the idea that these drugs, in fact, are safer to use from a kidney and blood pressure and potassium standpoint than our wonderful ACEs and ARBs and ARNIs for that matter.
I agree. And in DAPA, as you mentioned, in DAPA CKD, there were 0 cases of DKA in the dapagliflozin treated arm, which is, I think, very important and may very well be related to a lack of glucosuric effect. So why would you have DKA if there's very little or no glucosuria? Not no glucosuria, but very little clinically relevant glucosuria. So I completely agree with that. And I think the analyses from EMPA-REG outcome around GFR dip and around safety were very illustrative. And not only do we look at diuretics and RAS inhibitors, we also looked at NSAIDs in that analysis. The one of the worst poisons we can think about for the kidney. And there was no signal, fortunately, around the small number of patients using NSAIDs. There was no signal around a greater than expected dip, etc. So that was also very, very helpful. And there's also another question about the I'm just seeing in the chat about patients with GFRs of less than 30, which is sort of tied into what we're saying. And based on DAPA CKD, I am using these therapies down to the level of around 25 for kidney protection in people who have the profile that would have fit into DAPA CKD. Recognizing as well that in Credence there were also about 300 patients who had GFRs of less than 30 just because they were screened and then got into the trial. So we have at least some data showing that there, and about 10% or so of DAPA CKD patients had GFRs of less than 30. So we have some data to emphasize the use in those patients. But of course, we'll have much more data down the road once we have results from EMPA-KIDNEY, which we're all very, very much anxiously looking forward to.
And when you think about this from a historical standpoint, consider the fact that people with GFRs below 30 have been systematically excluded from all the heart failure studies, all the CKD studies, because people, were worried. And, there's a paucity of data. So these newer studies are really going to be, I'm very excited that they are now around for us to start to look at the opportunities here. And I hope we'll see the same thing with MR blockade. I mean, we just finished, we're nearly done recruiting. One of our NIH grants is to examine the use of spironolactone 25 in people with advanced diabetic kidney disease on atherosclerosis. And we're actually, it's quite low dose MR blockade is quite well tolerated. But, in the big scheme of things, we're going to need, as I mentioned earlier, more of an appreciation and more precision in choosing now our wealth of drugs to really make a difference in our patients. And I think the beauty of the SGLT2 inhibitor is that so far so good, it appears to cooperate quite well with existing therapy in providing risk reduction and safety, which I think is really the critical factor we all want.
So just picking up on that sort of stream of thought around patients who've been excluded from previous trials, the other, I think, really important part about EMPA-KIDNEY is not only going below 30 and having more data on those patients, but also having the normo or microalbuminuric patients who have also been excluded from previous trials, like IDNT and RENAL and Credence and DAPA CKD. So that'll be important, not only looking at renal protection, but also getting at the potassium issue. So what happens when the patients with GFRs of 20 to 30, those are the patients where we tend to see the risk of hyperkalemia. come out, not because of the SGLT2 inhibitor, but because of their kidney disease. That's where we also tend to stop other therapies. We tend to stop RAS inhibitors sometimes because patients don't tolerate them because of hyperkalemia. So I think all of those questions are going to be super important to look at in patients with low function who are at higher risk of hyperkalemia, and to see what the impact is of being on an SGLT2 inhibitor in that trial. So I think that'll answer a couple of very key unanswered questions that haven't been able to be looked at in other trials because of the design of those trials.
And I think the question about people with and without diabetes still hasn't been fully addressed. Obviously, if there is any effect on glycemia, we might see an effect, at least on intravascular levels of potassium, if not necessarily total body levels. And then to one group of patients which is excluded from all the trials, all the large trials, is transplants. And we did have a question before the seminar about effects in transplants. I suspect none of you are using SGLT2 inhibitors in transplants. I don't know, Professor Weir, you're an early adopter here.
Yeah, I mean, there are some studies. There was a very nice study that I reviewed for Diabetes Care, which had a reasonable number of patients. You know, it was a couple of dozen where they'd used it and shown safety. I probably have about 5 or 6 patients who are transplants on it right now. I mean, the big issues there is you want to make absolutely sure there are no drug-drug interactions with existing immunosuppression. And more often than not, these are people who have, you know, GFRs in the 45 to 60 range. So, you know, certainly we have data on that in people without transplants. But I'll be honest with you, one of my fascinating considerations is whether or not the renoprotective benefits that we've observed in traditional kidney disease, whether it's diabetic or non-diabetic, and I agree with your statement about non-diabetic so far, may also help in terms of allograft nephropathy, you know, subclinical, you know, fibrosis and scarring and tubular atrophy that occurs, likely due to alloimmune mechanisms, but maybe also due to the CNI. You know, there's lots of debate out there. But, you know, this whole theory of whether tissue starvation, which is one of the prevalent theories, and autophagy and helping autophagy rather than interfering with it, as we see in diabetes, may be a helpful part of these therapies in people with transplants. And so need more data. Someone needs to do some more studies in this regard, particularly mechanistic studies. And the beauty of transplants is, guess what? We do kidney biopsies in these people fairly frequently. So there's more of an opportunity to actually get some tissue understanding of what's going on.
Yep, and the other important point about transplant is that there's really equipoise with regard to ACE inhibitors and ARBs, in that there is no demonstrable trial that showed that there is a beneficial effect with an ACE or ARB in the setting of kidney transplantation, which is a big wide door to walk through for new therapies like SGLT2 inhibitors. I guess that's one interesting point. And then the other thing is that it's a denervated single kidney, so the physiology may be very unique and different. So I think I agree with you that mechanistic studies are very important, and we have a small heart and stroke grant looking at that question now, as do others. So I think that's an area that's going to continue to expand. There was a question above about low protein diets. Can I just respond to that briefly? So it's a hard question to look at in mechanistic studies. We can sort of infer from estimates of protein intake using 24-hour urine urea collections. So we are currently doing analyses looking at the effects on GFR and albuminuria based on urine urea excretion levels, high versus low. So we'll have data around that in the future. And it's an interesting question because high protein diets are linked with changes in tubuloglomerular feedback and afferent dilation and so on because of amino acid reabsorption. So that is a very interesting question, and it does need to be explored and looked at so we can perhaps give our patients advice about the interaction between protein intake and effects of these therapies. So a very interesting question.
Can I ask you, Alberto, so I know that CKJ kindly published EMPA-Kidney rationale paper. Are there other papers in CKJ about SGLT2 inhibition you'd recommend?
Well, we have made, excuse me. have made a couple of reviews on the topic where we have tried to provide a holistic view of the role and recent advancements. So I would really recommend, and you mentioned them earlier. And I also had a question, that something that Professor Weir raised, which is the concomitant medication. To what extent what we are seeing or we are failing to see regarding potassium levels might be influenced by changes in RAS blockade, adjustment of doses, or even stopping the drugs in the placebo group?
Well, I mean, according to the studies that were conducted in Canvas, the staff were encouraged to maintain RAS blockade. And as far as I'm aware, the percentage of patients that had changes in RAS blockade were minuscule throughout the study. But again, that was Canvas, and those people had pretty good kidney function when you think about it. So the likelihood of changes in serum potassium being related to cessation of RAS blockade is probably quite low. But I'm pretty sure, I don't have all the data in front of me to say, but the amount of people that had the drug stop was very, very low.
Yeah, and there are analyses from some of the heart failure trials. They looked at the patients who were taking a more than or less than 50% of the doses of these other therapies, and at least with regard to outcomes and safety profile, they were similar with regard to patients taking more than or less than 50% of these potential potassium raising drugs. So there doesn't seem to be anything obvious there, but I don't think it's been looked at in DAPA-HF. I haven't seen analyses specifically for potassium around that question.
Great. Well, actually, I think we've addressed everyone's questions as best we can, and it's been really interesting hearing about potassium and SGLT2 inhibition. So thank you very much, Professor Weir and Professor Cherney, for all your time. I think we've learned that we shouldn't be expecting clinically meaningful alterations of potassium, at least increases in potassium when we start our patients on SGLT2 inhibition. And it's not like starting RAS inhibition. And I think Professor Weir is arguing that a fire and forget policy might be something we should be considering, and that they are at least maybe more safe than starting RAS blockers. So hopefully there'll be a bit more evidence to see over time, perhaps even from DAPA CKD, looking at acute changes in EGFR and potassium in those early visits. Please visit the CKJ website for the open access review articles on SGLT2 inhibition, as well as Professor Weir's paper and the Kidney Rationale paper. I hope you'll join us again in February when the topic moves. We move to peritoneal dialysis and more randomized evidence, a trial assessing the optimum duration of antibiotic therapy for PD-associated peritonitis. So we look forward to seeing you then. Thank you very much.